Good evening and welcome to the UP Community Health Town Hall Series for February 2023. My name is Elise Burr and I'm the director of the Northern Michigan University Center for Rural Health. I'm hosting this evening's program here in Marquette that's been organized in partnership with Dr. Kelly Kam, epidemiologist and assistant professor in the Department of Kinesiology and Integrative Physiology at Michigan Technological University. This evening's program will focus on pediatric oral health, and we have a great panelist, some great experts joining us tonight as guest panelists. I'd like to briefly introduce them to you. Here they are coming on. We have Dr. Andrew Peterson. He is a general and hospital dentist here in Marquette that has a private practice. We're also joined by Katie Wara. She is a health services director at BHK Child Development. Carolyn Hoy is joining us. She is manager of population health and quality management at Marshfield Medical Center Dickinson. Michelle Kawabe is joining us from downstate. She is the kindergarten oral health assessment program consultant at Michigan Department of Health and Human Services. And lastly, we have Heather Beavers, and she's also joining us from downstate. She is an early childhood oral health specialist at Michigan Department of Health and Human Services. And we're going to start off tonight with Kelly sharing some statistical information about pediatric oral health. Thank you, Kelly.
Thanks, Elise. Well, February is actually National Children's Dental Health Month, which is part of the reason why we selected this topic to share with everyone today. So it is an important topic. Many of us that have kids, as well as all of us having been a kid at some point in our lives, it's an important piece to think about. One of the reasons why this is so important is that cavities or dental caries are the most common chronic disease in children. And when we look at the numbers from this, kids age 2 to 5, about 25% or 1 in 4 kids have at least one cavity in their baby teeth at that age. And it is heavily associated with poverty. Children in poverty are twice as likely to have cavities than children who are not living in poverty. By the time kids get up to age 6 to 11, almost 1 in 5 children have a cavity in their permanent teeth. So when we put that all together, that's about by age 8, half the children have had at least one cavity in their baby teeth. And by the time they get to age 19, we're looking at about 1 in 5 children have untreated tooth decay. So it's really important that we understand some of these factors that are related to access to care and having good oral health. Cavities are certainly preventable, and as we'll hear from our speakers tonight, preventing these cavities and establishing good habits early in life is an important factor in having a lifelong good quality oral health. Some of the other factors that are related to oral health that have been found in studies, certainly as I mentioned, income is associated because of the cost that sometimes can be a factor in getting quality dental care. Free sugar in your diet. Hopefully not a problem in our age 2 to 5-year-olds, but for our older adolescents, tobacco use is related to poor oral health. Some of those habits, are they established habits of toothbrushing and good oral care? Have those been established? And our children fear and anxiety about going to the dentist? Also the parents' oral health and care. What are their habits? What are they establishing with their children, as well as the community's cultural norms? And then certainly accessible dental care. So as I looked up today, every county in the Upper Peninsula is considered a shortage of dental health professionals, except for certain parts of Baraga County. But the rest of us are all in these shortage areas. And as well as some insufficient fluoride exposure. So many of us are living in areas up here in the UP where we don't have fluoride in our municipal water supplies. So having that fluoride another way. And then looking at from a really big perspective, the commercial marketing strategies. So how are our systems marketing some of these unhealthy foods and drinks for our oral health, and who are they targeting those to? And certainly when we look at the impact of this, pain, infection. It can affect your growth. For children, it can affect their school absences, and certainly also the stress related to that pain, and any stress related to the appearance of untreated oral health as well, and cavities. So with that, understanding that we have a significant burden in our areas, and understanding what we can do about it, I'm going to jump right in with our first speaker, of Dr. Andrew Peterson.
Thank you very much for having me tonight. So the number one question we get from parents is when to see a dentist. And we get this, once a day practically. And the American Academy of Pediatric Dentists recommend that you see a dentist first visit, or by age 1. And so those first visits are very short with the dentist. We're taking a quick look to see if there's any major issues going on. A lot of what we're doing is giving information to the parents about diet and oral hygiene, and things that they may not understand, or reconfirming things that they do understand. So I'm going to kind of work through babies through about 5 years old on best oral hygiene practices and diet, and other things that we've seen in the last couple of years that have kind of changed around the pandemic and different things like that. So when your baby's born, you're doing milk in the bottle or breast milk, and that milk has a lot of sugar in it. And so even though there are no teeth in the mouth, it's still important to be wiping the mouth with a gauze at nighttime to help prevent infection. That milk protein and the sugars can build up and start to give thrush, or different things that we see in very young children. As kids start to get teeth in their mouth, I actually, with my daughter, continue to use the gauze for the first few teeth, because it is a lot easier than using a toothbrush. You can put a little bit of fluoride toothpaste on the gauze and wipe the teeth, just getting any debris off of that, and then slowly making a transition into a pediatric sized toothbrush. And they make a lot of great ones at the store. They have ones that are shaped like bananas and other little special kid treats, and they tend to not like it, but they become accustomed to it really quickly. And then right now, the recommendation is from the American Academy of Pediatric Dentists, again, to use fluorinated toothpaste as soon as the first tooth arrives. And what you want to do is use a grain size piece on the toothbrush, and because the child's not able to spit, so that they're getting the adequate amount of fluoride, but not getting too much at that point. What I find that is really helpful for kids is doing their brushing routine in the same manner every single night, doing it in the same place, brushing the teeth in the doing the right side first, the left side second, and then going into, flossing and any of the oral rinses that you would use. And so people start to ask, when's flossing important? And it's when the teeth start to contact one another. You're not just flossing to get food out from the contacts, but you're also trying to help strengthen and protect the gums as well. So, right away when children are young, flossing isn't as important, but once those 3-year molars come in, they'll start pushing all the other teeth together, and that's when flossing starts to become important. I also recommend that parents start using mouthwashes for their kids when they're able to spit all of it out effectively. Act mouthwash works really good. They make a kid's version of it that has good flavors, and kids tend to really like that, and it can really help prevent cavities. The next thing is, a lot of parents tend to say to us that their kid's a really good brusher, and we know that that's not true. As good as we want to think that our kid is at brushing, until a child can effectively tie their shoes very, very quickly, they don't have the manual dexterity to be able to brush their teeth and getting all the spots. Now, that's what a lot of professionals say. I think that kids need help until they're about 10 brushing their teeth because they're just not doing an adequate job. So going in, letting them do it themselves, and you checking and, getting those other spots next. So then talking about diet a little bit here. Transitioning away from the bottle when they're young to a sippy cup. We really want to make a effort to try to get them away from having that suction in their mouth, so that they are having good formation of the bones of the mouth, and we can start to see some orthodontic issues if you're not going away from the bottle too early enough. So going to a sippy cup, which isn't great, that still produces suction. I really like those 360 cups. It requires that the child bites on the edge of it, and then they're able to get the drink out of there. Moving on with that suction, just the same with pacifiers. We're trying to get kids off pacifiers by the age of 3. Now, I know that's a challenging thing for parents to do. So trying to start weaning kids by, 18 months or 2 years, starting that weaning process so that by 3, we can absolutely be done with the pacifier, because that's when we start to see these skeletal changes that can really affect their overall oral health for the rest of their life. And, we hear it daily that they're just baby teeth, they don't matter. And we know that they will create problems if they have problems for the rest of their life. So taking care of what they have, because the growth and development that they have with these baby teeth can really affect a lot of things, including their adult teeth, including the jaw bones. And so we want to make sure that parents realize that it's not just baby teeth. They're not just going to fall out. They mean a lot more than just the, 12 years that they're going to be in the child's mouth. Talking about different snacking things. We found that prior to the pandemic, actually, we were seeing a decrease, at least personally, in the number of cavities that kids were having. We were seeing kids coming in that had cavities for years, that they were just having less and less and less. But kids were at home with their parents. Their parents were working from home, and the kids were snacking. And the parents were, giving them what they want so that they could, get their work done. And we've created a lot of really bad habits when it comes to snacking. So if we are snacking, we want it to be vegetables, fruit. We don't like to snack on throughout the day, but so getting back to snacking, we want to have our portion and then be done with it. We don't want to kind of munch on it all day long, because that's where we start to get cavities. Every time we have something that has sugar in our mouth, the acid attacks our mouth for 15 minutes after that exposure. So if you have a cracker that is a simple carbohydrate, it turns right to sugar in our mouth. And so you have one for 15 minutes, that acid is attacking our teeth. You have another one 15 minutes, and that slowly becomes that all day, the acid is attacking our teeth. So a lot of kids that we see have a lot of cavities. The number one reason that I take children to the hospital are Cheez-Its and Goldfish crackers. Between those two things and juice, I don't think I've seen a child that those things weren't part of their diet. The Goldfish and the Cheez-Its are simple carbohydrates that stick in all the grooves of our teeth. That I know all of us have had them at some point, and they're just stuck there. Even when you brush, they don't want to come out of there. And a lot of kids are what we call grazers. So they'll have a bowl of Cheez-Its or Goldfish, and they'll sit there and have a handful. 15 minutes later, have another handful. And so that acid is attacking their teeth all day. And then the other really big misconception that we see is, with juice. Parents say, "Oh, I water down my juice," and they think that that is a lot better. We know that that's kind of an old wives' tale, that any exposure to the sugar or the acid, it may be less, but it is still bad for our teeth. And so what I tell our patients is that we want our kids drinking water, milk with meals, or water. And one thing that I really recommended and have had really good success with is telling parents that go to the store, let your child pick out a water cup. That is their special water cup. They can have as much water in that cup as they want. They can have it all day, and that's their special thing. And it's a good thing for parents that have introduced juice early on. The kid really likes juice, and this is kind of a nice transition out of that. So.
You, Dr. Peterson. I can say as a parent, I feel like I've made all those mistakes at one point or another. On the brushing, so we see these automatic toothbrushes. Are those useful for kids kind of at the more towards the 8 to 10-year-old range, or should we still be keeping track of making sure they're getting the help at that point?
So the research is still really early on those. There's only been one that's had some really good research. It was called the 6 or 8 second toothbrush, and it was designed for adults that have special needs. That toothbrush is about $500 because it has to be made exactly to your mouth by impressions and has to be replaced every 6 months. So these new ones that you're seeing on all the social media platforms that vibrate, and I don't know how good and how effective that they are actually getting into the spaces, because they are a generic tray that's going in there. It's one size fits all, and we definitely know that in oral health that's not true. So
Thanks, Dr. Peterson. And we may come back with some more questions tonight. I just want to announce that if you're just now joining us, this is the UP Community Health Town Hall, and tonight's topic is Pediatric Oral Health. We have a number of experts that are joining us this evening to talk about this. If you're following us on Zoom right now, please feel free to enter any questions for us in the Q&A at the bottom of your screen. And if you're listening on the radio, please feel free to email questions to ruralhealth@nmu.edu. And we'll do our best to try to get through some questions and follow up with our panelists. Our next guest is Katie Wara, and she is coming to us to talk about what they're doing right now at BHK Child Development. And Katie, if you can start by kind of introducing what BHK is, in case we have listeners who aren't familiar with that, and then tell us about what you're doing right now regarding oral health.
Yeah, thanks for having me. BHK Child Development is a nonprofit community agency, the largest provider of early education and care. We serve over 500 children and families in Baraga, Houghton, and Keweenaw counties. Our staff provides comprehensive, individualized education and family support services to expectant women and children birth to grade 5. BHK operates early Head Start, Great Start readiness programs, out-of-school time, and tuition-based programs. Through our work, we strengthen and support positive outcomes, economic stability, and well-being for children, families, and our community. We also have strong established relationships with our community agencies and school districts to assure continued coordination and collaboration in the delivery of high-quality services. The children and the families that we work with come from at-risk backgrounds. We have approximately 2,000 children ages birth to 5 that live in BHK's service area of Baraga, Houghton, and Keweenaw. Of these, about 350 students are eligible for early Head Start and Head Start income-based programs. 52% of our enrolled early Head Start and Head Start students are eligible due to income that is at or below 130% of the federal poverty level. The remaining 48% of our students are eligible due to public assistance, homelessness, or foster care. Some of the initiatives that we have been a part of, given the fact that we do have a service area that is designated as medically underserved for primary care, dental health, and mental health. This in conjunction with the at-risk factors of our students, such as the poverty, the homelessness, and foster care, makes it imperative that our program remain hyper diligent in ensuring that our students receive health screening and assessments to meet their health needs. We know that school readiness begins with health. The way a child develops early in life directly affects future cognitive, social, emotional, language, physical development, which in turn influences school readiness. At BHK, each child receives developmental and health screenings during enrollment to identify any possible concerns or needed referrals for services, especially in the areas of health and dental care. As a Head Start program, we are required to identify if students have a primary oral health care provider and whether they are up to date on the schedule of age-appropriate preventative and primary oral health care. If students do not have a dental home and or are not up to date on their oral health care visits, we are required to help parents navigate resources and access oral health care for their child. Once a dental home is established and students are completing dental visits, we are also required to monitor any necessary follow-up treatments. Our program promotes effective oral health hygiene by ensuring all children with teeth are assisted by staff in brushing their teeth with toothpaste containing fluoride once daily. Building oral health into our daily routine at school is an important step in teaching children and families how to establish oral health routines at home. Parent collaboration and education is essential when teaching children the value of good oral health. We integrate the creative, cavity-free kids curriculum, which is specifically designed for early Head Start and Head Start programs. The curriculum includes parent education using vivid pictures and realistic descriptions of decay and cavities, along with parent-friendly information on how to prevent decay. Some of the challenges in addition to our underserved region for dental and healthcare is normalizing children seeing a dentist at or before 12 months of age. As a program, we provide parent education on the importance of establishing a dental home, and we're excited that we have 77% of our early Head Start students reporting that they have a dental home, but only 56% have either not seen a dentist or are behind on their preventative dental care. A possible way to make oral health care normalized in our student body is to provide school-based dental programs. Pre-COVID, this was a valuable oral health initiative that we were a part of, and we hope to offer this again in our early Head Start and Head Start programs. The school-based dental program we offered was a collaboration with Upper Great Lakes Family Health Center. It provided dental screening and assessments to BHK early Head Start and Head Start students in our classrooms. UGL's dental staff visited our classrooms providing oral health assessments, oral health education and instruction, teeth cleaning, fluoride varnish, cavity risk assessments, and sealants. The initiative removed barriers for parents, such as taking time off of work and school and transportation issues. Following the screening, the assessments, parents were provided a dental report card and encouraged to schedule an appointment with a provider if further treatments, such as fillings, were needed. We're just very proud at BHK to promote and educate our students and families on the importance of early and regular dental visits, ensuring our students value good oral health.
So Katie, I have a question for you. Since you work with young children, what are some of the signs that, if a child is too young to really say that they're in pain or that they might be having an issue, what are some ways that you're able to identify, that it could be potentially something with their mouth?
So one of the first steps that we do is building a relationship with the families and getting a family report and just trying to understand if they're seeing any concerns, especially at home, such as eating or sleeping. Try to get a picture because they know their children the best. And so by having that open dialogue and communication with the families, we can understand some of the behaviors or concerns that are happening at home, and if we're seeing them at school. Some of the things that we might see in the classroom are, not wanting to eat certain foods, maybe some sleeping issues, but again, really talking and helping the families understand that they can share that information with us, because we really want to support them in being open and recognizing just normal development, and then asking for help if they need any assistance in accessing dental care.
And when you talk about the statistics that you shared as far as those that have a primary care dentist, that they're taking their child to, what do you think are some of the biggest barriers that families are encountering right now when it comes to oral health?
So one, definitely the normalization, just not being aware that, as our previous panelist, Dr. Peterson said, that not being aware that when that first tooth emerges, that's a time to initiate a relationship and establish a dental home. Normalizing that, I think, would be one of the greater steps in ensuring that students access regular, consistent dental services. Another barrier that we're seeing with our student body is limited providers that are accepting Medicaid. So as I had shared, we do have a high number of students that are at or below 130% of the poverty level, or are on public assistance because of that. So we do run into some issues with them getting access to providers that will accept their insurance.
Great, thank you. And thanks for everything you're doing for the kiddos up in that neck of the woods. It's really great. So we've heard a little bit about what's happening up in the Houghton area at BHK Child Development. Now we're going to drop south a little bit and hear from Carolyn Hoy. And she is the Manager of Population Health and Quality Management at Marshfield Medical Center, Dickinson. So thanks, Carolyn, for being able to join us tonight.
Thanks so much for having me tonight, Elise. My background is actually different, I think, than everyone else on this call, because my background is critical care nursing. And what got me into this oral health was I was reading research on the incidence of pneumonia in oral health, and we were about to do a rapid sequence intubation on a patient in their 30s, which is uncommon. We don't typically have someone get that sick that quick. Having just read this research, I asked this patient how often they brush their teeth typically, and this patient replied, "I never brush my teeth. No one in my family brushes their teeth. We just have bad teeth. We get our teeth pulled and we get dentures." This patient had 4 teeth left, and it was a shock to me to see that. So we started digging more into our ICU population, looking at how frequently our ICU population was brushing their teeth. And what we found was that there was a correlation between people who died of conditions such as sepsis, COVID, and pneumonia, and their reported toothbrushing habits. So we knew we had a problem. In addition, we looked at our data coming out of the ED. What we were seeing is that about 2% of our overall ED population were coming in with dental complaints, but we saw a huge health disparity with our populations of self-pay patients, where 6.2% of our self-pay patients were coming in with dental complaints, and 4% of our Medicaid patients were coming in with dental complaints to our ED, which isn't really as good as being able to get to a dental office to work on dental complaints. So like it or not, dental has been dropped in our lap in healthcare. And until we come up with creative ways to partner with our community dental partners, we're either going to work on it in the community, or we're going to be seeing patients in the ICU. And our huge preference is to move the preventative route and help encourage and promote positive health behaviors. So I was able to get a hold of Kim Crabtree from Smiles on Wheels, who is absolutely amazing. And I am honored to be speaking for her tonight because this has been her work over the last 10 years to establish Smiles on Wheels. And Kim was able to establish a Smiles on Wheels clinic in our primary care center once a month, getting a dental hygienist in our primary care center to do oral assessments, to do fluoride varnish, sealants, and then a lot of education, because what we're finding, and this is a theme I'm hearing from other panelists, is so much of oral health and so much of overall health is due to these family health habits that are passed down from one generation to the next. So the neat thing about being able to get Kim and Lisa, our hygienist, in the primary care center is there is typically another family member there. So what this allows us to do is give all the good education like Dr. Peterson talked about in terms of diet and toothbrushing, and we are able to ensure that both the kid and the parent receive it. Another reason we're so excited about this is we're really trying to see kiddos after that first tooth erupts, maybe when mom and dad haven't thought about making that dental appointment. And the ultimate goal of Smiles on Wheels is to establish them with a primary dental home. And I just thought that was wonderful. Katie, you spoke of 70% of your patients having a primary dentist, and that's really the goal. The clinic only has enough volume to see, our goal is 7 patients a month, so nowhere near enough. So that's where we're hoping to go, and I'm really inspired to hear about your stories.
Thanks, Carolyn. So we heard Katie talk a little bit about some of the barriers that were up in the Houghton area. Are you seeing anything different down in Iron Mountain area?
The biggest barriers we're seeing is transportation is huge in especially the Medicaid and low income population. One barrier we saw is that when people have an income of greater than $50,000, we see 80% of them have a dentist. When that income level drops below 25,000, we see only 60% of those patients have a dentist. And there's a lot of things, a lot of that's due to barriers, not accepting Medicaid. And these families just don't either have the time, resources, or money to take a day off work and drive a couple hours to a Medicaid provider. So that's one thing that's been really great about Smiles on Wheels. Our target population are kiddos who do not have a dentist. It does not matter whether you have insurance or not. Our main criteria is you have not been able to find a dentist, and our goal is to get you paired with a dentist and a dental home.
Well, kudos to you for doing what you're doing right now in that community. That's terrific, and it'll be interesting to continue to follow the statistics, to see the impact that's being made down there. And my hope is that maybe people listening tonight will reach out and potentially partner and maybe collaborate on some additional oral health projects in our area.
Our long-term dream is actually to get a hygienist in our OBGYN clinic to screen moms who are expecting. Poor dental hygiene can cause premature labor, premature birth, and also to get their dentition taken care of before they give birth so that they aren't passing the germs that cause cavities to their newborn babies. We're hoping to find some additional funding to be able to start that pilot project.
That's great. Well, I think that'd be terrific if that happens. It's reaching the right people at the right age, helping with all that preventative care that can actually take place. So thank you.
Thank you.
If you're just joining us tonight, this is the UP Community Health Town Hall, and we are talking about pediatric oral health with a number of experts from around the state. Next up, we have Michelle Kawabe, and she's joining us from downstate. Lucky you today, based on the weather. Michelle's going to talk a little bit about the kindergarten oral health assessment program that has more recently been passed and what progress is taking place right now kind of throughout the state as well as our region. Thank you, Michelle.
Thank you, Elise, for inviting me to be a panelist and spread the word about this new program, the Kindergarten Oral Health Assessment Program. I oversee the program for the state. This is a brand new program, and it was created in response to legislation that was passed in late 2020. We officially kicked off this past fall in select areas of the state. So our dental screening program operates very similarly to vision and hearing screening programs, where local health departments employ screeners, or in our case, registered dental hygienists, to go into preschool programs, Head Start locations, childcare centers, public, private, charter schools, really anywhere that you'd find kids that are getting ready to enter kindergarten, and the hygienists perform no-cost dental screenings on the kids that are getting ready to enroll into kindergarten. And the screenings are really important for many reasons. As you've already heard, tooth decay is so common in kids. Almost half of Michigan Head Start children already have tooth decay, and close to 1/3 have untreated decay. And this is significant because cavities can cause a lot of pain, and that pain can make it really hard for kids to concentrate. It can prevent them from eating well. It can prevent them from sleeping. It can cause problems with speaking and speech development. And as you can imagine, all of that can affect a child's learning ability and their ability to perform well in school. And these problems can also affect a child's socialization, their self-esteem, and, as you've already heard, their behavior. And so the dental screenings look for urgent or unmet dental needs and refer the children for dental care if it's needed. And screening is also an opportunity to provide that education to children and their families on the importance of good oral health, and to educate them on good oral health habits that hopefully will last them a lifetime. So the assessments, all it is a simple open mouth screening. It takes just a few minutes, and the hygienist looks into the child's mouth with a pen light and a tongue depressor and simply documents what they see. So there's no treatment done, it's simply an observation. And the parents will receive a slip of paper to take to the school as documentation of the screening. Now, if something concerning is seen during the assessment, the hygienist will let the parent know what the problem is and provide a referral to a dentist if needed.
So Michelle, I know that I think it's great that this kind of screening has come into play. I mean, hearing and vision has been around for years now, and it's great to see that they're recognizing the impact, that oral health can have on children. As this is getting rolled out throughout the state right now, just kind of curious as to the areas that are lacking providers right now, and how is that impacting, getting this kind of rolled out in the state?
We're implementing the kindergarten dental screening program in a phased approach. As I mentioned, it's a brand new program, and as you can imagine, it's a lot of area that we have to cover. So we are currently in phase 1. It's fully underway and operational, and we selected the health departments participating in phase 1 based on their capacity to implement. So the program has not reached all areas of the UP yet. It's currently operating primarily in the eastern half of the UP, so Luce, Mackinac, Alger, Schoolcraft, Chippewa, and Marquette counties. And our plan is to expand to all areas of the UP, actually all areas of the state, by the end of 2025. And so if parents are located in a county where the program is currently up and running, know that the school should be sending out enrollment packets notifying you of the need for the dental screening and how and where to get screened. And in the western half of the UP, just sit tight for right now. We'll get the word out through the schools and the health departments to let you know about it when the time comes.
And Michelle, can you tell us, is there a cost for this screening?
There is no cost for the screening. If it's done through our program, through the local health department. I will note that parents do have an option to have their child screened at a private dental office if they choose. But our experience has been just like hearing and vision, they can have those screenings done at a private physician office, but most parents elect to have it done at events such as a kindergarten roundup, some type of pre-enrollment health fair that the preschools or Head Start settings may have. So again, there's no cost to the parents for the assessment.
Okay. And do you have any idea how long it'll be until there's, we can actually see an impact from this being rolled out?
That's a great question. So the program has multiple goals. We want to increase the number of dental screenings among kindergartners, increase access to dental care, and a third goal is to increase awareness of the importance of oral health among children and families. And I think that's a theme for this evening, it seems. And that's definitely a goal of our program. And some of these things we will be able to measure in the short term. We can look at programmatic data collected from the health departments to see the number of screenings that were done, the number of kids that were referred for treatment, the number of kids who had cavities, the number of cavities that were untreated, and so on and so forth. But the long-term impact of the program is expected to be improvement in oral health among children, but seeing evidence of this is obviously still a few years out.
Sure. What about how are these children being identified and tracked, and like how do we know who might not be in school the day that a screening is taking place, and how do they get that follow-up?
Well, every local health department operates a little bit differently. And the schools and the local health departments are expected to work together to identify the kids who, for whatever reason, didn't have the opportunity to be screened. So it could be, as you mentioned, they missed that day in school, or there was some type of barrier to having the assessments. So again, the health departments will work with the schools to identify those kids.
Great. And if parents that are listening wanted to find out more about this program, can you tell us where would they find this information? Where is that available for them to learn more about it?
So schools are a great place to start. Again, as I mentioned, schools that are in counties where the program is up and running will be sending out information, and they should be able to answer any questions that parents have. Parents can check with the school or the preschool to see if it will be hosting a pre-enrollment event where they can have the assessments done. Another really good source of information is the local health department. They do a great job advertising their services in places such as community newsletters, community papers. They all have a website and social media presence. So they definitely will get the word out about the program. And MDHHS website is currently under development and hopefully will be ready for launch by midsummer, this coming summer, where the public will be able to go for general information about the program.
Great. That's terrific. I remember when this was first trying to get passed as a bill, and I feel like that's great that I was able to be alive and watch it go from phase 1 to now it's getting implemented. So it's kind of exciting to see legislation work, and see how the advocacy is moving toward the benefit of our youth right now.
Yeah, absolutely. And it's exciting to be a part of it and to work to expand the program to all areas of the state. And again, to ultimately see that improvement in oral health among our youth.
That's great. Thank you. And next up, we have Heather Beavers. She is the Early Childhood Oral Health Specialist at Michigan Department of Health and Human Services. And she's going to talk a little bit about the Varnish, Michigan program. Welcome, Heather.
Thank you, Elise. Such an honor to be here tonight and talk about oral health. So my name is Heather Beavers. I am a dental hygienist, and I administer the Varnish, Michigan program for the Department of Health and Human Services. This is a program where we collaborate with medical providers to do oral screenings and provide fluoride varnish. And the reason that we do this is so that they can talk about the age 1 dental visit and really establish, a dental home. The infants are going for their well child visits, and this just really kind of goes hand in hand, talking about the importance of oral health, so they can identify any needs, talk to their caregivers about, anticipatory guidance, talk about what is normal, what is not normal. And Medicaid does reimburse for this. We give free fluoride varnish, and then the medical providers collect some very basic data, how many kiddos are screened, how many fluoride varnish application, some race questions, just some basic info. And then we really try to help them work with referrals to a dental home in their area. And it's mainly for kiddos 0 to 3, but really Medicaid policy reimburses for oral assessments and fluoride varnish every 3 to 6 months up to age 6. And we really, again, our emphasis is referral to a dental home by age 1. Dr. Peterson did a great job talking about all the important stuff about the age 1 dental visit, but we really can't talk about that enough. The medical providers do have to take an online training course. It's called Smiles for Life. It's a great 1-hour training video where you just kind of learn some basics about oral health, how to do a knee-to-knee exam, what to expect for fluoride varnish, and what to expect, what's normal and what's not normal, right? So I went and talked to medical residents yesterday down in Monroe, and I asked them, I said, what do you learn in medical school about oral health? And you want to know what they told me? They told me that they learn to brush your teeth and floss. That's all they learn in medical school. So I was kind of very surprised about that. So our intent is to just collaborate with medical providers and dental providers and really talk about how important preventive measures are, fluoride varnish, oral assessments, so that Dr. Peterson doesn't have to take them to the hospital, right? Because nobody wants that.
I want to just comment, Heather, something you just said makes me think about, what we could be doing with the students who are at the college age right now, going into these health related fields and making sure that this is taking precedent when they think about this, before they go off into practice too. So, what can we be doing to work with our nurses, the different people in residency right now, and really kind of bringing this to the forefront.
Because the mouth is part of the body, right?
Yeah, right. So what kind of follow-up is done or can be done for the referrals? Like, how do we make sure the child goes for care and that those barriers are being overcome for them, once it's initially identified?
So the Michigan Oral Health program, and I'm a resource. I can help with anything that is needed in any area. Obviously, the referral is the big key, right? One of the major challenges I will say that medical professionals have is that not everybody's like Dr. Peterson, and there's a lot of, unfortunately, dental providers that don't see kiddos until age 3, even though that's the standard of care. The American Academy of Pediatric Dentistry, American Academy of Pediatrics recommends it. People, some providers are just nervous about the knee-to-knee exam. And as Dr. Peterson knows, the kiddos, when you do the knee-to-knee exam, they're probably, when they come for their first dental visit, they're going to cry or scream, right? That's a very vulnerable position. But you know what? We can see inside their mouth better when they do that, right? When they scream, you can see better inside their mouth. And the key is getting them to the dentist on a positive note so that they think the dentist is fun. Because when they come at 3 with a lot of decay, their first visit, it's a negative one. It's treatment. It's getting an injection. That's no fun. We want them to have fun, ride in the chair, play with the water. You know, the dental office has some very different sounds, smells, and sights, right? I mean, when you walk in a dental office, it's a very different thing. And we want that to be normal and fun.
That's great advice. We used to do that at one of the clinics where I worked. We would have kindergartners come in and we would take them on a tour of the medical center, the dental center, and then we would actually have police talk with them as well. And you know, in the medical center, we had the skeleton with the bones that they would play with and put into different positions. And then we would take them into the dental center and they would squirt the water at each other and play with the different things. And it was pretty exciting to see, you know, and I really liked engaging with the children that way. One of the things it did make me think about is, you know, we went over flossing, brushing, kind of taking care of their teeth, but it occurred to me that the parents weren't there. And it made me think about, you know, we could go over this with children, but once they go home, it's really up to the parents to help reinforce that kind of behavior. And, you know, what do you suggest for ways that we can better educate the parents right now, just of the general public who maybe aren't going to a dental office at this time?
That's a great question. And I'm so excited to tell you that there's an adult dental Medicaid redesign. And there's increased benefits and increased services. And some of you may watch the Healthy People 2020 webinar. And it specifically talked about how if parents don't go to the dentist, they're probably not going to take their kiddos to the dentist, right? There's a direct correlation. And some people even, unfortunately, they threaten their kids, right? With like, oh, you're going to get an injection when you go to the dentist instead of positive experiences, right? So we are at the department absolutely thrilled, and it's a historic thing that there is increased reimbursement to 100% of the average commercial rate now for adult dental benefits, and increased services like crowns, root canal therapy, and periodontal coverage. I don't think people really understand how huge and what an investment this is in healthcare in Michigan, and so happy to have hopefully an increased provider network, and so that people don't have to wait so long for treatment, right? Because healthy people, you know, equals prosperous communities. We want healthy people in our communities.
Have you seen any other kind of legislative moves right now toward advancing, or is there anything you can share that might be on the horizon that's taking place that might help to you know, benefit everything right now in the oral health world?
Yeah, there is a new kind of mid-level provider called a dental therapist that can practice in Michigan. To my knowledge, currently nobody has applied for licensure, but this is kind of like a nurse practitioner, a mid-level provider, and it's in between a dentist and a dental hygienist. The bill specifically states that they need to practice in certain healthcare settings and they can only do certain procedures, but we're really looking forward to seeing how they fit into the community. Because again, if you call most any dental provider right now, there's a huge workforce shortage, and you're talking at least sometimes 6 months, if not more, especially a lot more of the specialties to get in. And that's a concern. When people have active infection in their mouth, they need to be seen now, not, you know, 6, 9. I mean, hospital dentistry that Dr. Peterson does. I mean, there was a time where dentists were telling me it was, you know, 18 months before they could get in for treatment.
Yeah.
And if you had an infection anywhere else in your body, right, we wouldn't be waiting 18 months. So
right. Heather, we just had this question come in over the Q&A from one of our Zoom listeners, and they're wondering, when will the added benefits covered by Medicaid go into effect?
great question. Proposed effective date is April 1st, 2023. That is the proposed effective date. There is not a final policy on that, but thank you for asking that question.
And Dr. Peterson, we had another question also come in that I wanted to ask you, and that was, you know, we heard from Carolyn a little bit about what she saw in the clinical setting when it came to oral health. And we mentioned earlier that you were a hospital dentist, and honestly, I never even thought about a hospital dentist. Can you talk a little bit about some of what you're seeing, I guess, at that hospital level as well?
Absolutely. So, children that are normally between the age of 2 and 7, we will take to the operating room. If they have trouble sitting still, have some behavioral issues, if there's a lot of work that needs to be done, we also take adults that have special needs that aren't able to sit and have their dental work done in the chair. On average, when we take a child to the operating room, they are having at least 6 of their 20 baby teeth that have cavities in them. Very often, I am doing 12 to 20 of the baby teeth. I mean, that can include baby root canals and extractions. And I mean, I've seen everything from, filling all 20 teeth to we've had cases where unfortunately I've had to take out all 20 baby teeth on, children as young as 3 years old. So there is a huge need in the Upper Peninsula here, and at one point, and it's gotten a lot better, but unfortunately, there were 100 kids waiting to be seen in the hospital, and there are unfortunately not a ton of hospital dentists up here. I think there's 4 or 5 in Marquette County, and then as you get up into the Keweenaw, I think there's 1 or 2, and down near Iron Mountain 1 or 2 as well. And so it's but once you go onto the east side of the UP, I don't think there's many people doing it, and I'm not aware of anyone actually. So
we should put a call out there right now for anybody considering dental. If you want to be a dentist or a hygienist, and you're young and you're going to go to school, please come back. Please work with us in the Upper Peninsula right now to try to increase that access to care. That's a big call. Kelly, from the epidemiologist standpoint, is there anything else that comes to your mind for any of our panelists?
Well, I guess for the hospital-based, my question is really related to that idea of how do we get providers here? So working within systems, either as for Dr. Peterson and Carolyn as well, what are the systems doing to try and recruit people here? How were you successful at getting a hygienist into the Smiles on Wheels program? What can we do to incentivize people working in this field to come up here? And Carolyn, if you don't mind starting.
So I feel so fortunate to have Lisa from the Smiles on Wheels program, because there is a huge shortage of hygienists, as we've talked to different stakeholders, both here and in northern Wisconsin. And one of the neat things I actually heard of is some different programmings, both through Marshfield and Elise talked about through NMU, to try to work on getting more members into those fields. One thing I think that would work well is we have some tech schools for high schoolers, 10th through 12th grade. I think it would be a wonderful idea to let them shadow hygienists and see if we can recruit before they even graduate from high school. And that's been very successful in other fields.
Yeah, I mean, hopefully we've got a bunch of youth listening to this tonight, right? So I just want to thank all of you panelists. You've been absolutely terrific. I can't thank you enough for joining us on such an important topic tonight to talk about pediatric oral health. My hope is that, people who are unable to listen to tonight's programming will be able to watch the recording of our show at nmu.edu/rural health, where we'll have that available. Thank you to everybody once again for coming on tonight's program, and I plan on staying in touch with all of you. So thank you.
Thank you.
Thank you.